Welcome to the first grand rounds of the season. Thank you, Dr. Ayler, for starting all this and allowing us to present. So I figured that I wanted to talk to more about as you can see here, zoonosis, AMR, antimicrobial resistance, and the One Health Game Plan, which is a concept that's spearheaded by the CDC that I wanted to talk about. But besides just talking about that, I wanted to also include a clinical case, do it a bit different this year, and then talk about some high yield, zoonotic infections. I know we've always talked about it, but that's what I'm currently studying right now for the board. So I decided to make, topics about that and then go into this CDC One Health Game Plan, which I thought was a cool concept that really ties in us, the animals, and the environment. I know Lauren last year did her, grand rounds on climate change and all that. And even Becky, you talked about Campylobacter. So I'm going to mention some of those few points and the idea behind all this. All right. So here's a clinical case that I actually presented last year, but I thought it was pretty relevant for this talk. Basically, 73-year-old male, really no significant past medical history, just degenerative joint disease, had bilateral knee arthroplasties. He presented to the ER basically after a cat bite and a scratch to his left hand and forearm 2 days prior to arrival. All right. As you can see there on the slides, just AFib on Eliquis was the other past medical history, and then of course that surgical history, which is pretty significant. For social history, as I always do, in an ID fashion, Ocala, that's where he's born, lives with his wife, retired Navy veteran, 3 vaccinated cats, fever, chills, and malaise are the names. TB exposures denied, dental issues nothing, and the rest of his social history is pretty much unremarkable. Then as we always do, physical exam, just scratches to the left hand. I'll show a picture. I don't know if you guys can pull it up or because you could see there.
Yeah.
Vital signs are fine. Here's that hand. Yeah, whatever. You could see it's pretty bad. You could see the puncture wounds just at the snuff box anatomical site. And below that, there's also a 4th cat, which is a porcelain cat named Rigers. That's what the patient said. So as it's a cat bite, yeah. So as you all are aware is that cats, their teeth are more needle-like shaped, so they hit deeper structures. The only thing on the CBC was just leukocytosis, neutrophil predominant, 13,000, but other than that, pretty much bland. CMP also negative, just the K a bit elevated at 3.2, but nothing too significant. Right. So other tests. So we, of course, got blood cultures. That was significant. It did show an initial gram stain of gram-positive cocci, but the CT was more concerning, really showing some sort of tenosynovitis, some edema, soft tissue edema over the aspect of that left hand. Quickly, just a hospital course. We used Amsulbactam. We transitioned to, Amclav after that, but then the gram-positive cocci hasn't yet initiated, but when we knew about that, we had to switch the vein. Fortunately, this gentleman did leave AMA because he had to feed his cats, which he had 3 cats, or the 4th one if you want to include Rigers, but he did have to come back because we called him and said hey, it's actually growing Staph aureus in your blood, that's not good. He's like, all right, fine. The orthopods were consulted, of course, in their own fashion, no need for surgery, classic. And then, of course, thankfully, we're like, all right, let's get this guy back on antibiotics. It's redraw cultures, blah, blah, blah. It's specialized with MSSA, right? So then we had to switch all therapy from Vanquinero down to Cefaz. 14 days, did all that. That's what we wanted to do. But then he left AMA once again. Then we're like, all right, we'll give this guy benefit of the doubt. He'll be adherent. So we just switched to cefadroxil. He was doing better, in the 3 days that he was there. But other than that, we didn't get any other word. All right. So that's that. So I thought it was a good opener for these high yield points on zoonotic infections. I know we've already had multiple talks. But most of these that I saw, especially as I go through the ID board review, I pulled from David Aronoff over at Indiana University. I wanted to specialize on really 4 types of zoonotic infections that I feel like are pretty prevalent, but devastating that if we do have it here in the USA, which I'll talk about the names. Okay, just a introduction, zoonotic pathogens, majority cause of our consultations as an ID physician. And not only from like the type of pandemics or the type of consultations we get, but these types of infections have caused multiple epidemics and even pandemics throughout the decades and years. This slide, I just wanted to make it prevalent that it's very important that say like throughout history there was like the Spanish flu, the Black Plague, blah blah blah. These are all due to zoonotic infections. So it's pretty important for us as ID to have an idea of what type of association from the bacteria, parasite, what have you, virus to the animal and even into an environment in the bigger play. There are many types of zoonotic infections. These types of slides, these next two slides that I'm going to show, it's just meant to make associations of the type of animal and the type of I guess microbe that it has. You don't necessarily need to memorize, but it's just a good reference, especially a day after your boards, to just go through these slides to get an idea of, the picture of the bug with the animal. The yeah, the main reason also, even though these types of, I guess parasites, bacteria, viruses are on here, the case that I presented with the cat growing the staph, you should always remember also like skin flora, like strep, staph, whatever, is also highly even more common than these types of bugs that I'm going to mention. But these are obviously the ones that the boards like to talk about. Which oh, Nifa.
It's one that presents a lot in the Southeast, in South Asia and Southeast Asia.
Thank you.
Can you go back one slide to see okay. Okay.
Yeah.
Dr. Tony says the beach looks like a 9 kilo.
Jack, yeah. Yeah, Aeromonas.
Logo.
Yeah. I'm not going to talk much about the Aeromonas hydrophila, but just a high yield fact on that they could probably ask on the boards. That's usually associated with freshwater infections. All right. And also could cause a gastroenteritis, this Aeromonas hydrophilia. All right. So there's different routes of infections, of course, for these zoonotic diseases. The ones that I'm really going to hone in on are cutaneous and also direct animal contact with tissue or the animal itself. There's four of them that I'd like to really go through: cat scratch, cutaneous anthrax, tularemia, and brucellosis. Excuse me. Why did I pick these? They're prevalent enough in the United States that that I've actually seen a lot of questions on doing my review. So these are some highly yield topics that I like to talk about. Of course, we got vector-borne, lepto, all that, as you could see on the slide, which I'm not really going to talk about. And then Q fever is also a big testable point. So the first one, Bartonella henselae, cat scratch disease. I know that we've already talked about this for the most part. It causes, different forms of the disease, but the most devastating is like the best bacillary agematosis, especially the immunocompromised. It can affect, the liver, spleen, eye, or the CNS, right? One thing that I wanted to highlight with that type of manifestation is don't get confused with another, cutaneous lesion that could be seen in a similar patient population is Kaposi sarcoma, right? The one that you could see, KS or Kaposi sarcoma, it's more of a plaque-like. This is a classical type. There's different types of manifestations. I chose this picture. It's more violaceous. It's flat. When you actually manipulate the lesion, it's not as bloody or friable as opposed to BA or bacillary agematosis, as you could see on the right of the slide. It's more nodular-like lesions. Usually they could present very similar. These could get very confusing, especially if you just see it for the first time on a patient. But there's certain high yield points, right? Kaposi's is due to HHV8. Bacillary agematosis is due to a bacteria. So if you give antibiotics, the lesion is getting better, it's most likely bacillary agematosis than this viral infection. But the patient population is similar, right? HIV, AIDS, transplant, very immunosuppressed. So that's one thing I wanted to point out. Moving on, like Bartonella henselae, as I mentioned, at least 13,000 cases per year, majority of which are less than 21. There's certain diagnostic features with this in the lab that they could present on the exam. Stellate abscesses on biopsy, a wart and starry stain, usually is positive early, and of course these are fastidious and slow-growing gram-negative bacilli. Right. Don't forget though that some of these serology tests that you do for this type of species could cross-react with other species, like say Bartonella quinata or something. All right. Azithromycin. I'm not gonna go much into the treatment, but I just put like a high yield fact, like azithromycin. You should just know that. So here's what a stellate retinitis looks like. They're pretty much lipid exudates that form a macular star. So say on the exam, you see like in the stem, like an ophthalmologist or an eye doctor sees this on a retina, fundoscopy, and you see a star burst appearance, you should think of Bartonella henselae as a cause. All right. Um, Furthermore, this is a wart and starry silver stain, right? This is pretty tall tale sign that you have some sort of Bartonella henselae infection. Not many stains actually present like this. So if you see something like in a gold background with black bugs, microbes, it's pretty much going to be this type of stain. And then you could pretty much associate it with a cat scratch disease or Bartonella henselae. All right. I'm just showing like what type of lymph nodes are usually affected after the cat bite. So say on the guy's left hand, the axillary lymph nodes are pretty much inflamed. So anthrax now, bacillary anthracis. This is also number 2 of the 4 that I wanted to talk about. I'm not going to go more into like bioterrorism. I'm only going to focus on like the cutaneous animal type exposures here for this talk. Right, 95% community associated cutaneous for the most part, pruritic pale, usually exposed to some sort of animal hide or goat hair. One way they could usually express or describe these types of cutaneous lesions in the past is they used to say cigar burn with surrounding edema. Pain is usually not present, but it could be present as well. For bacillary anthracis, for the diagnosis, the most interesting thing about this bug, these are usually non-modal for the most part. I don't know if they'll give this on the exam, as opposed to other species in the family, like other Bacillus, those are usually modal for the most part with flagella. So in particular, bacillary anthracis, and then you get on the stem, say the lab tech said that these are non-modal gram-positive bacilli, then yes, you need to think about this type of bioterrorism, alert the lab kind of thing. All right. Doxycypro, but usually these types of weaponized strains, if they're using for bioterrorism, are of course heavily resistant. Okay, inhalation, ingestion, or other modes of transmission. Here's a picture that I wanted to show. All right, this cutaneous lesion of this gentleman. You could see it's very necrotic in the middle, blisters and vesicles surrounding it. This was actually painless for this guy, according to this UK journal that I saw. But he was manipulating some sort of like animal hide, I believe, when I was reading that article.
What's that?
Or like fur, skin,
Oh,
skin, fur. Yeah. And then the third one that I want to talk about is tularemia, Francisella, which I think will be usually talked about a lot on the boards. Ticks, deer flies, rabbits, squirrels, all that. Even a cat bite can cause this. The way we were taught, like hunters skinning an animal or rabbit, but generally speaking, it's more, that's pretty old school now. It's going to be probably talking more about like a veterinarian who's been manipulating with these types of, animals. It also presents with like a red tender local lymph node at near the inoculation site, similar to like cat scratch disease. But the way you could differentiate the two between these diseases is usually Francisella. One, it's actually a lot less common than Bartonella here in the United States. And these patients present sick. They're like really sick versus people with like cat scratch disease. All right. Ulceral glandular is the most common manifestation of tularemia. Um, I'll talk more about the other manifestations on the next slide. Diagnosis here, all that. Buffered chocolate yeast in chocolate agar like Legionella. Those are the types of cultures. Serology, PCR, gentamicin is usually the treatment of choice. This slide, there's many manifestations of tularemia, right? I got this from CID, which was I was coming across this during my research. It was published in a supplement back in just last year. I'll show the cover page on the next slide. It had a good, treatment update plan and all that about just tularemia in itself. You guys want to learn more, but you could see 28% ulceroglandular, 27% oropharyngeal, and then pneumonic and glandular just come, second, and all others are pretty much less than 10%. Here's that supplement that I read, well, highly skimmed over. If you guys want to look more in just tularemia, it's pretty good. Here's a picture of somebody, I think she was 68 or 70-year-old male, who had worsening right-sided lymphadenopathy, swelling, and pain, presented after a week of fevers or 2 months progression of this, lesions after a cat bite, actually. Got a lot better after a month of doxycycline. So this is also glandular tularemia that they were able to diagnose over a New England Journal. All right. And this,
I'm sorry,
yeah, what's up?
that here where the bite site at? Like, did you get it in the neck, or did you get it in like the arm?
I think it was like a site, it wasn't in the neck. So,
So it's downstream.
yeah, sure. Yeah. I remember. Yeah, this person wasn't bit at the neck. It was like, I think it like the arm or something, and it, I don't know, got infected, like cat scratch disease. How the regional lymph nodes got infected. Yeah. This article that was also published in the New England Journal back in the early 2000s. This is that famous one, Martha's Vineyard. That bunny rabbit got mowed over, and then they found out that that one individual in the study case series had pneumonic tularemia. So this is it. So they might ask that on the boards as well. So tularemia gets shed in the stool of like rabbits and bunnies, and then it could get aerosolized after like landscaping. So that's how these individuals got. And this is the article. Brucella, the last one that I think is high yield. Brucellosis is usually the disease that it causes. A direct contact with any bodily fluids, animals, etc. Unpasteurized dairy from infected animals, depending on the species, you could have an idea. One interesting fact of brucellosis, it has multiple forms of presentation. It can infect the bone, liver, endocarditis, sacroiliitis, but epididymal orchitis is usually what they like to talk about, like on question stems. I tried finding out as to why this type of bacteria actually like goes for those organs, but we don't really know why. But that's usually a presentation that could present on a question stem or epididymal orchitis. And this interesting, clinical presentation, like malodorous sweating, basically. It's uncommon, but it's apparently pathognomonic according to some publications. I mean, after I work out, shit, I have brucellosis. I'm joking. But yeah, but that's something it's pretty specific to this bacteria, malodorous perspiration for some reason. And of course,
Yeah, it's
Yeah.
big sense. Like
I don't know. That's what they describe. Yeah. I don't know. I have to go more into that, but they don't know how that happens. But that's what I've seen that's been described in literature related to this bacteria. So yeah, something you might get on the boards. There's different sources for Brucella, right? You don't just necessarily need to know the species, but if you have an idea, if they say on the question stem the patient was drinking like, unpasteurized milk, whatever, from a goat, you could pretty much think it's Brucella, like meltensis, I should say, versus like canis from a dog. You don't need to know the, species name, but there's different types of species that is related to different types of, the product of the animal. Okay. I wanted to put on a slide like the types of I guess different microbes that are very highly infectious that lab need to be alerted. So I put it here. The prophy, the post-exposure prophylaxis, whatever, that's a lookup, but the pathogens all the way on the right of the slide is more important. Right, Neisseria, MTB, brucellosis, tularemia, anthrax, melioidosis, Burkholderia, Q fever, all of that, and also the fungus. They're all aerosolized for the most part. Most of these are especially easy to like grow on like aerobic culture and all that. And the risks as I have here in the middle. Most of these pathogens have the potential for doing bioterrorism. Okay. And don't forget, even like cocci, histo, and blasto also has a potential for bioterrorism. If you guys ever suspect this, you should call the lab and tell them they should be careful. All right. So here you go. All right. Now getting to what all this was. So the One Health approach, right? All these zoonotic diseases, all that. I found it interesting that the CDC has many approaches and campaigns, I should say, and education for the community. That it's not just the animal and the human, it's also the environment, right? Climate change, what have you. Veterinarians need to be involved with this because the type of antibiotic prescriptions that they're giving to their, clients, the pets, is also causing downstream effects for resistant bugs and when we get it in humans, right? So it's like, oh, this is cool. So here you could see I got all this from CDC, coordinating communication, collaborations on what we should do and learn. Um, multi-sectoral, transdisciplinary strategy, which really they're just trying to connect everyone, to get an idea and better education on how to go about this. So why does it matter for us? As I've been, pretty much saying, as an ID physician, over 60% of our diseases are pretty much zoonotic. Antimicrobial resistance is huge. Environmental factors, vector-borne, emerging infections, climate change, and all that can cause different shifts in patterns in disease states. Public health reporting, AMS, collaboration, clinical management, all of that. Yeah. I'm pretty much gonna keep saying what I'm just reiterating what One Health is. Some key players, medical professionals, veterinarians, ecologists, policymakers. We're trying to get like newer laws out there to help, combat like just antimicrobial resistance and the animal use, veterinarians and not just for humans. So trying to work with different types of vector-borne policies, mosquito control, and all that. So it's pretty interesting. Outbreaks, biodiversity, global health security, these could all be pretty much prevented. Um, the idea is getting multiple, specialties involved, even if they're a healthcare provider or not, will pretty much downstream effect have optimal health for the individual. All right. So here's some real world examples on how this could be implemented. So rabies vaccination campaigns. I know we already think about that, but it goes more than just the, physician and the patient. It goes on like how animal control is done, how, clean the city or places, the town is, antibiotic use in livestock, enter environmental cleanup projects for vector-borne diseases. So this first case study, like rabies vaccinations, public health officials, veterinarians vaccinate the animals, reduce rabies globally. That's good. All right. You do this, you give them post-exposure prophylaxis. You have to collaborate with the local veterinary services and the dog vaccination campaigns. And then you have to educate these individuals on what to do, how to clean up bite. Highlighted this post-exposure prophylaxis. Why? Because it's important. And what is it? It's this. This is going to be on our test. All right. If you guys already know, there's different classifications. I'm just going to cite here. Sure you guys know, but there's different classifications for a wound, right? Especially for like a dog bite. If you're in a third world, you get this on a test. What they're going to usually ask you about is for a non-immunized adult, all right, for rabies vaccination. So what is it? All right. So you have to determine, are they immunized or not? Of course, it's probably going to be non-immunized. Is it a dirty wound? Is it not? It's going to be a dirty wound. And they classify how deep the wound is. If it's a dog bite, you could just assume it's already a class 3 because the other 2 classes don't worry about that. It's going to be a class 3 on the test. This is what you're going to do. Obviously, always clean the wound, whatever, iodine, all that, disinfectants. You have to give them immunoglobulin if they're non-immunized, if they never had the vaccine. So non-immunoglobulin, or immunoglobulin, excuse me, IG, at the site of the wound, all right, and around it, for a full dose. And what's a full dose? 20 international units per kg. So if you fill the site and you still have some remainder in the vial, you actually give it IM at the same anatomical site. I don't know. It's 20 IU per kgs. I don't know. I have no idea. You have to do the math. I'm not a math guy. Sorry, Becky. But yeah, you start with the IG first at the site, 20, whatever, you calculate that, and any remaining, you have to give it to the same anatomical site, usually a deltoid because it's IM, all right? And then you follow that up with a vaccine, okay? 4 doses, especially day 0. Where? Correct. Yeah. Somewhere else. But correct. See? You guys see that? I love that. Good job. Yes. And this is 4. They may get tricky on you and they're going to say it's immunocompromised, so then it's 5. And yet it's day 28.
It's
An additional vaccine, right? But then if you're immunocompromised, you have to do a 5th dose. All right. But it's just 4 doses, 0, 3, 7, 14. So say at day 3, moving on for your 2nd dose, can you give it at the same anatomical site where the IG was initially placed 3 days ago? Yes, you can. You still can. If I remember, yeah, you still can. So it's only for the 1st dose. All right. Yeah. And don't forget also Tdap. All right. So that's its own thing. But just briefly, I don't have a slide on that. Right. The way I classify Tdap is if it's a dirty wound, clean wound, if they've been vaccinated, which is 3 doses or more, or unvaccinated, right? If it's a dirty wound, they've never been vaccinated, or you have no idea their history, you have to give the Tdap along with IG. Okay. If it's a dirty wound, they've been vaccinated, then you have to determine how long ago. If it's more than 5 years ago, then yes, you have to just give the vaccine. You don't need the IG. If it's less than 5 years and it's a dirty wound, they've been vaccinated, then you do not need to vaccinate. Okay. If it's a clean wound and they've been vaccinated, you don't have to do anything. If it's a clean wound and they have never been vaccinated or you don't know, and it's been more than 10 years, then you have to give the vaccine. The way I think they're going to test that, it's going to be a dirty wound, of course, with this. And then it's going to be someone who's not been vaccinated. So then you have to give the IG with the vaccine. That's, yeah. The bite they could do, yeah. I don't know what they say. I don't know how much dirt. Yeah. I don't know what their criteria is for that. That's a good question, Mickey. I don't know.
Yeah.
Yeah. I don't know, but let's realistically, all the ER physicians think it's dirty, so which is fine. Better safe than sorry. Would you give the Tdap vaccine at the same site as the IG or the rabies vaccine? Yeah. Always try to do different anatomical sites. If the IG is in one place, try to keep it all in there versus the vaccine others. Okay. All right. Cool. Yeah. Please. Thanks. Yeah.
That basically instead of clean or dirty, clean is like non-tetanus prone and dirty is tetanus prone. And then it talks about age of wound, the depth, the mechanism of injury, if there's revitalized tissue or not, if there's contaminants like dirt and saliva. Obviously, if there's contaminants like dirt and saliva present, that's clear. Okay.
Every rabies.
Yeah.
Yeah.
The bat mounted or animal smelt. Very dirty.
Yeah, but like you said, like clean cut glass knife.
Yeah.
Those are clean, yeah.
Yeah.
And there's a similar example in up to date, I think.
It says 20 for the ml, it's really few mLs. It depends on the weight of the patient. So it comes down to, let's say for a 60 kilogram male or a 6 kilogram person, it'll be like 4 mLs.
What if we got bit in the face?
Well, I actually had from TDH that someone got bit in the ear, fertilized by a monkey in Chris. And they refused to give the immunoglobulin in the ear.
Right.
Really?
Like where would you put
Yeah.
it?
So we put it and I was like, but you can just put a little bit, please.
Yeah.
Don't say that.
Creative, yeah.
It's better.
I didn't know.
Right.
Yeah.
Okay.
Interesting.
So, before we move on to the
Yeah.
next case, right, we talked about rabies post-exposure
Mhm.
prophylaxis, and since we have a travel plan now, when is it indicated to do rabies pre-exposure?
Indicated in the emails.
Yeah, so if you have somebody that's a high-risk occupation, right, like a veterinarian, or they're gonna do some field work, and they're gonna be around, animals that could rabbit or stray, in rural areas, right? For an extended amount of time, you could consider. That being said, I'm not gung ho on
Yeah.
these vaccine before they travel. I don't do it often, those that have rotated with me, but there is a need for it, and it's important to have that.
Yeah. Thank you. Thanks, Dr. Pardo. All right. So the second, real world implications of this One Health approach, right? I've been talking about AMR use in livestock, the outcome slow development of drug resistant bacteria. They're even trying to do studies on like the antimicrobial resistance in tap water, water in general. Just a lot of bugs, obviously, it's polymicrobial, but there's work going on there on, I don't know exactly what, but that's part of this. So yeah. Environmental clean health projects, stagnant water, all of that, health communities, fewer diseases, outbreaks, vector-borne diseases, and of course, like climate change. Lauren did a great talk on that last year. You guys could go on ID podcast. Shout out to Lauren on she did it all on climate change. That was her grand rounds on this in ID. So oh yeah, she did too. Yes. So yes, please also check out ID podcast. Dr. Lauren Reibold. Yeah. Okay. Great. So no, thankfully, thankfully for yeah. That's funny. All right. So here are just some projects, the CDC spearheaded some success stories on this. In the Southwest US, Mexico, the brown dog tick can carry a germ, Rocky Mountain spotted fever in people and dogs. They were able to streamline this, free roaming dogs spreading the infected ticks. Many people got sick. Public health and animal health control, long lasting tick collars on dogs, regular pesticide applications, all that community education. Ultimately, only after 4 months, 99% of the dogs are tick free in the community, right? So it wasn't just from the dog and the humans. They want more on the environment, did all that, and they were able to make it into a success story. All right, here are more ideas behind this, more testing, more monitoring, detect illness in people, farms following standard protocols, help protect from an influenza pandemic. Great. All right, integrated surveillance, outbreak investigations, vector control programs, dengue, malaria, what have you. Yeah. Stewardship, this is a big one that I didn't really realize, but it's been going along a lot in like the breeders and like kennels and all that. Kennels, I should say, sorry. Veterinarians. Becky did a good talk as well on Campylobacter and kennel breeders that I think it was like 2016 and 2018. They started to see a large amount of like resistant Campylobacter, and then they were able to, I guess, trace it back to like puppies and dogs, like from the breeders. So there's now, I guess, education for the breeders to not prescribe so much antibiotics for these like kennels and like dogs. Because downstream effects, as I mentioned, they could become resistant to pathogens. Very interesting stuff. Want to learn more about that? That's also on ID podcast by Dr. Nowaki. What? Yeah, I did. Oh man. Yeah. All right. Okay. So here are some publications actually from the American Veterinary Medical Association. This first author, Dr. David Taylor, he's actually doing huge works on this. Thanks for him. He's over out of Colorado State. He's trying to put out these articles, try to reduce AMR, basically throughout veterinarians. The one that he usually found Recently, that trained veterinarians prescribed unnecessary antimicrobials less frequently than those further out of training. So that's it's saying that, you know, these veterinarians, I guess the longer out that you're in training, the more that you're more liberal to give antibiotics than those who are just fresh out of residency. What have you? I don't know if veterinarians go through residency, but yes. Um, which makes sense, but there should be more modules, I should say, or something, for them to learn. Here's another uh, article that Dr. Taylor over at Colorado State did, but he focused more on like just private practices of veterinarians. Among 16 breeders, 88% used antibiotics. Interesting. For what? For whatever infection. Obviously this is a bad, you know, practice. So there's works on that as well to really hone in on these types of private practices. Um, Education and advocacy, right? There's a lot of community outreach projects, policies. Um, they're even trying to get, you know, children. This is a Twitter banner that I saw that the CDC is doing for zoonotic diseases. For children, they have coloring books. So if you have children, you could color and help implement this education that we're all connected. I give this to my daughter daily. Um, I'm joking. So there's environmental health integration. What I found notice quite interesting is like animals are usually like one of the first signs that there could be like a disease in that area. So for birds, for instance, they could be dying off earlier to say West Nile virus. That's what's been studied, and that could be a telltale sign that there could be an impending like infection in the human population. So most of these, you know, animal deaths in an area could serve as an early warning signs that there could be a potential human illness. Even though these birds were dying earlier from the West Nile viruses, humans in that area weren't really showing signs at that time. All right. And then this could lead downstream effects that vector-borne, you know, protocols need to be in place in that area before humans start getting infected. Right? Because birds are the primary host of West Nile virus, and you know, um, insects, or I should say, what is it? Uh, Insects can, you know, infect that and then go into humans. All right. So that was cool. Vector-borne protocols for that for mosquitoes. And then here's just some resources for ID physicians, but pretty much the CDC has a great website on this One Health approach. But that's the way I usually try to go through, you know, when I look at a topic is like, all right, I'm studying about this. What is going like outside of just zoonotic diseases? How is environment impacted? And then I came across this. So I thought this was interesting. All right. Oh, and there's also Zoohoo. What was it? Zoonosis and One Health updates. It's a webinar series. Next one's in February 5th. I'll see you guys all there. All right. It's free. Um, Spearheaded by the CDC. It's free CE too, for our licenses, but they try to do this. It's for everyone if you just want to listen in. I've been doing this for the last few years. But it's great. It's good stuff. All right. This is it. Takeaways. One Health is essential. It's not just about the animal and us. It's about the environment and those who contribute to the environment. You want to be a leader. We're ID physicians. We're experts in this. So let's be an expert. Okay. Thanks, guys. That's it.